All right, let's jump right in. Did you know that while ectopic pregnancies only make up about 2% of all pregnancies, they are literally the leading cause of maternal mortality in the first trimester? It's a huge deal. If you're aiming for a 280 plus on your clinical boards, you absolutely cannot afford to have any gaps in your understanding here. The evaluation of early pregnancy bleeding and pain is not just some high-yield exam topic, it's an absolute life-or-death clinical scenario that requires incredibly rapid recognition and decisive action. Today, we are going to rigidly detail the intricate mechanisms, the discrete management steps, and those precise diagnostic traps that are specifically designed to trip you up. Let's get to it.
Okay, let's dive into this baseline stance. And frankly, there are no exceptions to this. Every single female patient of reproductive age who presents with abdominal pain or vaginal bleeding, you have to approach it as a ruptured ectopic pregnancy until you can completely, definitively prove otherwise. It forms the foundation of that classic diagnostic triad: pain, amenorrhea, and vaginal bleeding. You really must approach these cases with a massive index of suspicion because an unrecognized ectopic can rapidly, and I mean rapidly, evolve into catastrophic hemorrhage and hemorrhagic shock. So from this very aggressive starting point, we rely on precise diagnostic tools to quickly rule this deadly condition in or out.
And this brilliantly illustrates exactly what we're looking for. When you look at a normal intrauterine pregnancy, it features a gestational sac containing a yolk sac that's perfectly nested right within the uterine cavity. Conversely, the classic ectopic presentation reveals something entirely different: a thick endometrial stripe, an entirely empty uterus, and a complex adnexal mass. Now, this empty uterus, paired with an extrauterine mass, that is the absolute imaging hallmark of an ectopic pregnancy. But as we know, imaging alone rarely gives us the entire picture, which brings us to our absolute most critical laboratory metric.
Now we hit the discriminatory zone. This is the absolute serum beta-HCG threshold, and it is strictly set at 1,500 to 2,000 milli-international units per milliliter. Above this zone, a normal, viable intrauterine gestational sac absolutely must be visible on a transvaginal ultrasound. If your patient's beta-HCG is over 2,000 and the uterus is completely empty on imaging, it mandates immediate and aggressive ectopic investigation. Plain and simple, an empty uterus above this strict threshold is an ectopic pregnancy until proven otherwise. But what if the beta-HCG is below that discriminatory zone? Say it's sitting at 800 with an empty uterus. You cannot diagnose an ectopic just yet. This is exactly where we rely on the 48-hour kinetic surge. A normal, viable intrauterine pregnancy will demonstrate a vigorous, exponential rise in beta-HCG. It'll strictly double, or at the very least, rise by a minimum of 35 to 50% every 48 hours. However, an ectopic pregnancy, since it's confined to a hostile environment like the fallopian tube, will demonstrate a severely blunted, sluggish rise, or even a complete plateau. And don't forget the third variance: a feeling pregnancy or a miscarriage will strictly demonstrate dropping beta-HCG levels over that exact same 48-hour window. So how does this translate into discrete management steps? Well, when you have a patient whose initial transvaginal ultrasound is non-diagnostic, meaning an empty uterus but no obvious mass, you must temporarily monitor them based entirely on that initial beta-HCG. If the beta-HCG is below the discriminatory zone, the strict mandate is serial testing every 48 hours to assess those kinetics we just talked about. But if the initial beta-HCG is greater than 2,000 and the ultrasound is equivocal, the strict clinical mandate is to repeat both the beta-HCG and the ultrasound in exactly 2 days to definitively locate that pregnancy. All right, once an ectopic pregnancy is actually confirmed, the decision between medical and surgical management is absolutely paramount. And let me tell you, the pharmacological boundaries for methotrexate are incredibly strict. You literally cannot bend these rules. The absolute criteria are as follows. 1, the patient must be perfectly hemodynamically stable. 2, the unruptured mass must be strictly less than 4 centimeters in diameter. 3, there can be absolutely no fetal heart tones. And 4, the baseline beta-HCG must be strictly less than 5,000. Every single one of these clinical criteria has to be perfectly met to safely proceed with medical management. So the crucial takeaway here is knowing exactly when medical management is off the table. If your patient shows any markers of rupture, things like tachycardia, hypotension, or peritoneal signs like severe guarding, methotrexate is absolutely contraindicated. But remember, surgery is also strictly mandated if the mass is greater than 4 centimeters, if there are positive fetal heart tones, or if that beta-HCG is greater than 5,000. And that is regardless of how perfectly stable the patient looks. The strict mandate in any of these scenarios is emergent laparoscopy. Let's isolate these variables to really cement this vital distinction. Picture a perfectly stable patient with an HCG of 3,000 and a 2-centimeter adnexal mass. They strictly receive methotrexate. But what about a completely stable patient with an HCG of 6,500 and a 3-centimeter mass? The strict mandate there is surgical laparoscopy. Why? Well, despite the stable vitals and the relatively small mass size, the failure rate of medical therapy skyrockets when the beta HCG exceeds 5,000, making methotrexate a highly dangerous proposition.
Okay, let's put all of this into practice with a Mastercase Blueprint testing deep integration. Imagine a 26-year-old female presenting with left lower quadrant pain and vaginal spotting. She is perfectly hemodynamically stable. We're talking a pristine blood pressure of 115/75 and a totally normal heart rate of 78. Her transvaginal ultrasound shows an empty uterus, a 3.5-centimeter left adnexal mass, and absolutely no fetal heart tones. But her quantitative beta HCG comes back at 7,200. Notice the massive diagnostic trap we are setting up right here.
Based on those exact parameters, we have to determine what is the definitive next step in management for this patient. Think about it. Her vitals are perfect, the ectopic is definitively unruptured, and the mass is well under 4 centimeters. This scenario is aggressively designed to tempt you into choosing methotrexate as the least invasive option. But I challenge you to rely purely on the absolute clinical mandates we just established to map out the correct life-saving intervention. Let's exhaustively break down the 5 choices here. Observation or a CT scan, those are simply fatal delays for any confirmed ectopic. So A and B are out. Now, intramuscular methotrexate, choice C, is the heavily tested distractor here. While her mass is small and her vitals are beautifully stable, her beta HCG is 7,200. That is an absolute contraindication to medical management. This strictly forces choice E, laparoscopic surgery, specifically salpingotostomy or salpingectomy. That high beta HCG completely invalidates her stable vital signs and her small mass size. I'll leave you with this final, uncompromising rule derived directly from everything we've just covered. Never let perfect vital signs blind you to laboratory contraindications. Methotrexate requires a completely perfect clinical picture. Anything less strictly mandates the operating room. Keep these exact thresholds anchored in your mind for test day. So, the next time you see a completely stable patient with a tiny ectopic pregnancy, ask yourself, what is the lab value trying to tell me that the monitor isn't?